Let's get started. This is the Telehealth Work Group meeting convened by the Special Committee on Mental Health Modernization and Reform. I'm sharing with you the agenda right now. Today we'll start off after brief introductions with an overview of the Kansas Telemedicine Act with Eileen Ma. Before I keep going, Robin, are we live?
Yes, you are live.
Terrific. Next, we will look at the vision statement drafted in the 2020 report and see if there's any revisions needed to be made there. Also look at the 2020 telehealth recommendations and work on any revisions there. And then the new topic that was assigned to this group was telehealth payment parity. So begin the discussion on that as well. All right, so I'm going to stop sharing. And I think it would be nice to do some brief introductions. So just name, title, and organization would be great. So I'm going to kick it off with who I see first on my screen. Representative Landwehr, can we start with you?
I'm sorry, Hina, someone was talking to me. What did you ask me?
No, you're fine. Just very brief introductions, name, who you are, title, organization.
Oh, Brenda Landwehr, State Representative, Chair of the Mental Health Modernization Committee. Thank you.
Thank you. Next, I have Dr. Chad Johanning.
Hi there, yeah, Dr. Chad Johanning. I'm a family physician in Lawrence, Kansas, and I'm representing Kansas Academy of Family Physicians.
Thank you. I have Claudia Tucker.
Good afternoon, Claudia Tucker, Senior Vice President of Government Affairs and Public Policy at Telehealth.
Connie Freeze.
Good afternoon, this is Connie Freeze, Blue Cross Blue Shield of Kansas City, Government Relations.
Next. I'm having a hard time seeing everyone on the screen. All right, next I have Jennifer Finley.
Jennifer Finley, Kansas Hospital Association.
Rennie Schuler McKinney.
Brittany McKinney, Advent Health, Director of Behavioral Health.
Sunny Mickle.
Hi, this is Sunny Mickle, Vice President of Government and Community Relations at Blue Cross and Blue Shield of Kansas.
Brittany Nichols.
Good afternoon, Brittany Nichols, EMSC Coordinator, Kansas Department of Health and Environment.
Senator McGinn.
Carolyn McGinn, Senator McGinn, Vice Chair of the Mental Health Modernization Committee.
Representative Neighbor.
One more, so just checking.
Representative Neighbor, did you want to introduce yourself? All right, let's try Jason Grenstrom.
Good morning, or good afternoon. I'm Jason Grunstrom. I am from the University of Kansas Health System. I'm the Executive Director for all of our digital health and post-acute care.
Thank you.
I'm sorry, I just unmuted myself.
Yes, hello, Representative.
This is Cindy Neighbor, District 18 in Shawnee, and I'm the newest member of the overall committee, and I'm listening in today because I'm not sure if this is the subcommittee I will be on or if there's another one. So it's a pleasure to be here.
Thank you. And have I missed anyone? Is Candace on?
Candace, it is. The 512 number is Candace and I, State Government Affairs with Cigna.
Great. And I saw another hand raised.
My name is Dennis Shelby. I am CEO of Wilson Medical Center in Neodesha, Kansas.
Thank you.
And hi, I'm Dorothy Hughes. I'm an assistant professor in population health at KU School of Medicine, but I am not speaking on behalf of the university today. I'm just here as a researcher.
Thank you, Dorothy. And Dorothy is one of our supplemental experts for today. The other two experts that we have on the call are David Fly from BSRB. Are you on?
Yes, I'm here. David Fye, Executive Director for the Behavioral Sciences Regulatory Board And the Assistant Director, Leslie Allen, I believe she will be logging in shortly if she's not already on the call.
Terrific. And then Kyle Kessler.
Good afternoon. I'm Kyle Kessler, Executive Director at the Association of Community Mental Health Centers of Kansas, and we represent all 26 licensed community mental health centers around the state.
Thank you. And I think I forgot to introduce myself. So Hina Shah, Senior Analyst at the Kansas Health Institute, and I am facilitating the telehealth work group. And so now I am going to turn it over to Eileen. I will say that we all need to remember if we speak to first say your name and your organization every time we speak for those listening in YouTube and other channels. So Eileen, would you like to go ahead and start?
Thanks, Hina. Hi, everybody. My name is Eileen Ma, and I am a reviser with the Office of Reviser of Statutes. It's my pleasure to be here with you today to discuss the Kansas Telemedicine Act. And just as background information, I'm actually the reviser who drafted the act back in 2017. So feel free to jump in if you have any questions as we go along. I'm going to share some documents with you, but they also came to you via email. Here we go. Give me just a second here, folks. I'm having technical difficulties. Okay. Okay, can you see my memo in front of you now?
No longer, Eileen. It was there before.
I'm sorry?
It's not there anymore. It was before.
Try again here. Sorry about this. Okay, can you see it now?
Yes.
Okay, thank you very much. Sorry about that, guys. So I provided a brief overview in my memo of what I'm going to talk about, and then I'm going to review the statutes with you contained in the Kansas Telemedicine Act. I'm also going to discuss with you briefly last year's House Bill 2206 and last year's House Bill 2208, the statute that arose out of it. Finally, just as a bit of additional information, last time we were meeting, there was a question as to which compacts were actually enacted within the state. So I've provided that information to you on the second page of the memo, and it's their corresponding statutes. So these documents I've provided as well, but I wanted to review the Kansas Telemedicine Act with you and do it while the statutes were in front so that everybody could take a look at them if you've never actually read the act. So KSA 40-22-2,210 is the citation to the act. The act is statutes number 2210 through 2216 in chapter 40 of the Kansas statutes annotated. KSA 40-2,211 is actually the definition section of the bill, the act rather, and I wanted to go through these in some depth because as we met last week, I did hear some kind of misconceptions about what the different terms were and what was covered and what was implicated within the act. So again, feel free to jump in and ask questions as I go along. It's important to understand that these definitions pertain only to the Kansas Telemedicine Act. They are not intended to be used in other statutes or for other purposes other than this act. So here we go. Distant site is the site where the healthcare provider is located while providing healthcare services by means of telemedicine. That's pretty basic. Healthcare providers, they're the physician, licensed physician assistant, licensed APRN, or a person licensed, registered, certified, or otherwise authorized to practice by the BSRB. That's a whole range of individuals that we decided not to list individually, but to go ahead and just kind of generically list. It's also important to realize there that the licensed physician assistant and the licensed APRN, that means licensed within the state of Kansas. In alphabetical order, I'm going to jump back down here to number 4. A physician means a person licensed, again, in the state of Kansas to practice medicine and surgery by the State Board of Healing Arts. By implication, the State Board of Healing Arts is here in Kansas. So again, that pertains to a Kansas licensed physician. Going back to number 3, the originating site means a site at which a patient is located at the time healthcare services are provided by means of telemedicine. That means wherever the patient is physically located. So the person can be in their car, they can be at their home, they can be wherever. It just means that the patient is somewhere else from where the healthcare provider is located. It's also important to note that here in number 5, this is the only place that implicates those 2 definitions of distant site and originating site. And here we say that telemedicine, including telehealth, means the delivery of healthcare services or consultations while the patient is at an originating site and the healthcare provider is at a distant site. Telemedicine shall also be provided by means of real-time 2-way interactive audio. That means telephone calls are part of telemedicine. Those items are covered. Visual or audio-visual communications, including application of secure video conferencing or store and forward technology to provide or support healthcare delivery that facilitate the assessment, diagnosis, consultation, et cetera, of a patient's health care. But telemedicine does not include communication between healthcare providers that consists of a telephone-only voice conversation or only an email or only a facsimile transmission. That means consultations that between, as an example, that means consultations between healthcare providers that only consist of those separate items. It also doesn't include communication between a physician and a patient that consists solely of an email or facsimile transmission. And subsection B just states that the act took effect on January 1st of 2019. It became effective in 2018. Here we have 40-2,212, and this pertains to confidentiality. Subsection A says that the same requirements for patient privacy and confidentiality under HIPAA as applicable that apply to healthcare services delivered in person shall also apply to those services delivered via telemedicine. And nothing in this section shall supersede the provisions of any state law relating to confidentiality, privacy, security, or privileged status of protected health information. If you look, I have also provided to you the combined text of all HIPAA rules. If you go to page 59, I just wanted to point out, this is the section that pertains to security and privacy, and all of these parts are hyperlinked to bring you to the actual page that talks about what you're looking for. It's a 115-page document. Again, it's combined of all the different rules all in one handy-dandy place, and I thought it was neat. So I wanted to provide that to you as a reference. So telemedicine, subsection B states that telemedicine can be used to establish a valid provider-patient relationship. This doesn't have to be done prior to the use of telemedicine. It means that telemedicine can be first contact between a provider and a patient and establish that provider-patient relationship. Subsection C states that the same standards of practice and conduct that apply to healthcare services delivered in person also will apply to healthcare services delivered via telemedicine. Those are the standards of practice within the the provider's licensing agency that the provider must follow. Subsection D1 basically is pertaining to follow-up. It says that a person authorized by law to provide and who provides the telemedicine services to a patient shall also provide guidance on appropriate follow-up care. That provider also, if the patient has a primary care or other treating physician and the patient consents, the provider who provided the telemedicine services is going to send a report to the primary care or other treating physician, a report of the services and treatment rendered in the telemedicine encounter. Subparagraph B states that a person licensed, registered, certified, or otherwise authorized to practice by the BSRB shall not be required to comply with these provisions that state that regarding the 3 business day follow-up. KSA 40-2,213 is the actual meat of the act. These are the insurance reimbursement provisions. Subsection A states that this section is going to apply to basically all health and group health insurance policies, medical plans, contracts, etc. It's also going to apply to these organizations that have issued contracts or renewals of contracts that have been delivered, amended or renewed on and after January 1st of 2019 when the act became effective. These provisions are also going to apply to the Kansas Medical Assistance Program, or KanCare. Subsection B states that basically insurers can't exclude a covered healthcare service from coverage by telemedicine solely because it's delivered through telemedicine rather than in-person contact. An insurer can also not deny coverage or exclude from coverage healthcare services delivered via telemedicine based upon the lack of a commercial office for the practice of medicine when such service is delivered by the healthcare provider. So if you have somebody who is delivering telemedicine from their home and they don't have a commercial office, that's not a reason for exclusion here. Subsection C states that the insured's medical record shall serve to satisfy all documentation for reimbursement, and no other documentation outside the medical record shall be required by the insurer for purposes of reimbursement. Subsection D states that the payment or reimbursement of covered healthcare services delivered through telemedicine may be established by an insurer in the same manner that payment or reimbursement for covered services that are delivered via in-person contact is established. Basically, this is just saying that the insurer's relationship to the providers don't really differ between telemedicine and in-person. And then nothing in this act should be construed to prohibit an insurer's ability to limit coverage to only those services that are medically necessary. They're not construed to mandate coverage for a healthcare service delivered via telemedicine if it's not already a covered benefit, covered healthcare service when delivered by a provider subject to the terms and conditions of the covered individual's health benefits plan. Or number 3, the insurer cannot require that a patient receive services exclusively via telemedicine. Subsection F just refers to the Kansas statutes that pertain to the test track. Basically, when we mandate coverage, and it's a new mandate, that coverage needs to go through a 1-year trial run via the state employee healthcare program. This mandate for the statute rather regarding the insurance coverage of telemedicine was not subject to that test track. And again, the act took effect on January 1st of 2019. KSA 40-2,214 pertains to the prescription of drugs via telemedicine. Basically, subsection A states that the Board of Healing Arts, in consultation with the State Board of Pharmacy and the Board of Nursing, were required to develop rules and regulations relating to the prescription of drugs, including controlled substances via telemedicine. And those rules and regulations were due to be adopted by December 31st of 2018 before the Kansas Telemedicine Act went into effect. And subsections B and C pertain to the State Board of Healing Arts and the BSRB. Those two licensing agencies were required to adopt rules and regulations necessary for the Kansas Telemedicine Act to effectuate the provisions of the Kansas Telemedicine Act. Again, those were due by December 31st of 2018, so that when the act became effective on January 1st of 2019, all those were in effect so that there was no delay. KSA 40-2,215 just states that the Kansas Telemedicine Act shall not be construed to authorize the delivery of any abortion procedure via telemedicine. It's kind of redundant because abortions by our statutes, the RU 285, I believe, requires in-person presence, and otherwise it's surgical, so that wouldn't be able to be done via telemedicine anyways. So that's KSA 40-2,215. Lastly, KSA 40-2,216 is a non-severability clause, and it basically states that if any portion of this act or the application thereof to any person or circumstance is held invalid or unconstitutional by court order, the rest of the Telemedicine Act will go down and become ineffective, as if it were not law. This is different from a severability act where the courts say we're going to, any portion of statutes that is not that is invalid or unconstitutional, they can cut it out, and the rest of the surrounding legislation in the act would still remain. This is the actual opposite of that, where if any portion is invalid or unconstitutional, the whole act will go down. In 2021, House Bill 2206 was heard by the House Committee on Health and Human Services. The bill would have made amendments to certain definitions applying to the Kansas Telemedicine Act, and it also provided that telemedicine could be used to refer patients to specialty services, and it established certain provisions regarding coordination of care. The committee ultimately took no action on the bill. I've provided a copy of it, but I'm not going to review the bill with you line by line. Finally, Senate substitute for House Bill 2208 was a rather lengthy bill. It had other provisions in the bill, but I'm only going to address the telemedicine provisions of it. It was new section 10 of the bill. It ultimately became KSA 65-28, 135, and it pertained to the authorization of telemedicine waivers for out-of-state physicians. And basically, This just grants the State Board of Healing Arts the ability to issue waivers to physicians from out of state so that the physician can deliver telemedicine services within the state of Kansas. Subsection A requires the State Board of Healing Arts to issue such a waiver within 15 days of receipt of a complete application. The conditions thereupon means the physician has to submit a complete application and have an unrestricted license to practice medicine and surgery in their state or another state in their state, or the physician must meet the qualifications required under Kansas law for a license to practice medicine and surgery, but that applicant cannot be the subject of any investigation or disciplinary action by the applicable licensing agency. Subsection B states that, again, a physician practicing telemedicine in accordance with this subsection shall conduct an appropriate assessment and evaluation of the patient and document the appropriate medical condition for any prescription issued. Subsection C states that nothing in this section shall supersede or otherwise affect the provisions of KSA 65-4A10 or KSA 40-2, 210 @SEEK. What this pertains to is those statements that an abortion cannot be authorized via telemedicine. Subsection D states that if any person who receives a telemedicine waiver is going to be subject to all the rules and regulations pertaining to the practice of their licensed profession and shall be considered a licensee for purposes of the Professional Practice Acts administered by the State Board of Healing Arts. Subsection E provides for renewal of those waivers. Subsection F states that a physician holding a license issued by the applicable licensing agency of another state may provide consultation through remote technology to a physician licensed in the state of Kansas. And what this means is if it's only for purposes of a consultation and the consulting physician is in another state and only providing consultation services to another physician in the state of Kansas, that consulting physician does not have to be licensed or waivered. The consulting physician does not have to be in possession of a waiver within the state of Kansas. Subsection G basically states that a healthcare licensing agency can adopt procedures consistent to allow this waiver procedure for the professionals licensed and regulated by that agency to practice telemedicine within the scope of practice defined by Kansas law for that provider's profession as deemed by the licensing agency to be consistent with ensuring patient safety. So the agency can develop procedures so that other healthcare professionals, other than the physician to which this statute applies, can also develop, the agency can develop a waiver process for those other individuals. Subsection H just says that nothing in the section shall be construed to prohibit a licensing agency from denying an application for a waiver. If you go back up to subsection A, where it says that the Board of Healing Arts is required to issue a waiver within 15 days of receipt of a complete application, this says that the licensing agency may deny an applicant a waiver if the licensing body determines that granting the waiver may endanger the health and safety of the public. In subsection I, please note that as used in this statute, telemedicine means the delivery of healthcare services by a healthcare provider while the patient is at a different physical location. I want to make clear that this statute pertains to the ability of a physician or otherwise licensed individual, healthcare provider from another state to practice telemedicine in the state. These are the requirements regarding the actual practice of telemedicine in Kansas. Their standards of conduct within their Professional Practice Act. It's different from the provisions of the Kansas Telemedicine Act. The Kansas Telemedicine Act basically is an act relating to insurance and reimbursement of the delivery of telemedicine. And I want to go back to
Eileen, I'm going to stop you for 1 second. We have a raised hand by Representative Neighbor.
Okay.
Yes, thank you. And good day, Eileen. It's nice to see you.
Hi, Representative.
On what you just described on the KSA 6528-135. I have a question on number 2. If a doctor has or is under disciplinary action in another state, why would we not take that seriously? Because if he's under rules and guidelines that's not letting him practice some part of his expertise or something because of inappropriate behavior, this seems to let that go.
No, actually what it's stated in the opposite language. So basically the statute says the State Board of Healing Arts shall issue a waiver if the physician holds an unrestricted license and is not the subject of investigation or disciplinary action. That investigation or disciplinary action would exclude the individual from being granted a waiver by the licensing agency.
Thank you. That clarifies that. I just may have misread it. Thank you so much.
Sure.
Eileen.
Yes.
Hi, this is Connie Freeze with Blue Cross of Kansas City. Quick question for you. So I just figured out something here, shame on me, but this 6528,135 appears to not allow the board that issues the mental health licenses to allow like a license, an LP, a licensed practice counselor or something to do telehealth. Is that correct? This would only apply to MDs, DOs.
At this time, it only applies to physicians, but as I stated in subsection G here, other licensing agencies, this authorizes those agencies to develop procedures consistent with these developed for physicians. So if the BSRB wanted to develop these procedures so that mental health professionals could deliver services via telemedicine, they can do that. This is the authorization for that agency to do this. At this time, the statute only applies to physicians. This is within the scope of practice again.
So I guess what I'm saying, do you think they understand that in terms of like, if we have an access issue and these types of behavioral providers, we don't have enough of them, then G would be a possible solution for the agency to expand and allow those types of providers to, that are licensed outside of the state of Kansas to practice.
What I want to say is that this is an alternate method for a healthcare provider to provide telemedicine within the state of Kansas. If for instance, if the BSRB did not enact procedures to issue waivers, a licensed mental health professional within with in another state could still apply for licensure via SIPACT, which is the compact for it's the Psychology Interjurisdictional Compact that becomes effective on January 1st of next year. So
Yeah,
it's
but
still,
wasn't that limited to psychiatrists?
I am not completely sure because I didn't draft that compact. I drafted most of the other ones. But
Okay,
that
I
one,
was just trying to find what we call physician extenders, or, you know, a lower level of practitioner that doesn't have the highest credential, you know, the highest educational to be able to serve his members. So that you've answered my question. We can move on. I just see this as an opportunity to allow those types of providers.
absolutely, and that's the point.
Yeah.
Keep in mind also, though, this is just the ability for those individuals to practice telemedicine within the state. As per the Telemedicine Act, the healthcare provider definition is specific to those healthcare providers with regard to the provisions of the Telemedicine Act. So
Eileen, Representative Blandwehr, I think probably Dave Fye with the BSRB could tell us on that site pack.
Sure, Dave, you want to jump in?
Sure. This is Dave Fye with the BSRB. And yeah, so the compact, the Psychological Interjurisdictional Compact, or SIPAC, would allow licensed psychologists, so the PhD level psychologist, to apply to the SIPAC Commission to register for an e-passport to practice in other compact states. So it would just refer to those PhD level psychologists or the licensed psychologist.
Okay, then it sounds like for those other mid-level type providers, the only other alternative would be to develop a waiver procedure for them to practice telemedicine in Kansas.
If that's what we, okay, Representative Blandwehr here, if that's what we chose to do, yes.
So Eileen, I think, are you done with your background of the Telemedicine Act? I think this is a nice transition point to start looking at the recommendations for the work group members to think through revisions. If you
I'm done if there are no other questions.
Great, thank you. I am going to share my screen now. And this is Hina Shah, KHI. Do you guys see the vision statement on the screen?
We do.
Terrific. All right, so the first thing I wanted to do as a group is take a look at this vision statement and let me know, based on everything you've heard today, how you've discussed last week, are there any revisions that you want to the vision statement for the 2021 report?
Hina?
Uh-huh.
Representative Blandwehr here. I guess the question that I have to ask is that we talk about telehealth. So does telehealth say video? Because I believe that we also have, and Eileen can verify in statute, that it can be done via the phone as well. So do we have to clarify that telehealth and phone issue?
Representative Blandwehr, in the definitions for the Telemedicine Act, it actually includes telehealth. It says telemedicine including telehealth, I believe is the language.
Okay, so is it your belief then that that takes and addresses the phone issue?
Yes, absolutely.
Would you want
Yeah, I
this
think, Hina, what
modification?
you're adding there, I like that, Hina.
Okay.
This is Shauna Wright with the Center for Telemedicine. I'm sorry I missed your earlier coverage, Eileen, but my question after I reviewed the Kansas Telemedicine Act was the way I read telemedicine to include telehealth, but I thought that it stipulated that it had to be televideo. That video was a component. So does the Telemedicine Act include telephone only as a telehealth approach?
Yeah, Shauna, you missed the overview, and I made that point specifically. If you look at the language in the statute, it's telemedicine shall be provided by real-time two-way audio, interactive audio, and then there's a comma, which sets that item separate from all the others.
Thank you.
Hina, Representative Landwehr again. The one thing as we move forward on this, because I don't think that we can separate behavioral health, telehealth, and medical telehealth if we're going to address our Telehealth Act as a whole. So our revisers need to keep in mind, as well as our committee members, that even though this is a mental health modernization committee, this particular work group is a little expanded just because of the subject matter. Am I clear as mud now?
Any questions from members? Thank you. Any other edits to the vision statement? And we can continue to edit. Go ahead, Sunny.
This is Sunny Mickle from Blue Cross of Kansas. One clarification just to help make sure that no one thinks that this is restricting what we already do today, where we added via video and phone. Can we make that and or phone? Because I think that's, again, part of that confusion. If you use the and there, it's requiring it to be video and telephone. And I do know that there are times when the video may fail and the provider is able to continue on with the service. So we can make that there. Perfect.
And this is Shauna Wright with the Center for Telemedicine. Sunny, do you think then that it should say televideo and or phone? Because video alone is not billable for telehealth, right?
Actually, video alone is still considered telehealth or telemedicine.
Shauna, hi, Sunny, I'm sorry to interrupt, but Shauna, it is in the definition that visual only is considered telemedicine.
Okay.
Again, take a, if the statutes are in the documents that I provided, it's 40-2, 211 that contains all those definitions.
Thank you.
Hey, this is Jennifer with KHA. Could we just maybe, instead of trying to define all this here, refer to telehealth as defined in the Kansas Telemedicine Act?
That makes a lot of sense.
This is Sunny Mickle from Blue Cross of Kansas. I support that as well. Thank you, Jennifer.
And hi, it's Eileen from the revisor's office again. Quite frankly, we would, if this portion were to become legislation and it would be in the Kansas Telemedicine Act, those definitions would apply throughout the Telemedicine Act. So we wouldn't even define them because the definitions would already be there.
Good catch, Jennifer.
All right. Well, thank you. Then I'm going to move us on to our first recommendation. So recommendation 10.1, quality assurance. This one again, take a few seconds to look at it. What is in red are some revisions that you began working on at the last meeting. And so you can take a look at that. And also the text that was, I'm going to make this a little smaller so you see it all. Let me know if it's too small though. So you can start thinking of if you want to incorporate the possible revisions into the update for this year.
You know, Hina, some of us are old.
I will zoom it back in.
Thank you.
Hina.
Uh-huh.
It's Eileen from the revisor's office, and I just kind of want to point out when it says standardizing cybersecurity practices, those practices are covered in HIPAA, and that's kind of the reason why I provided the HIPAA document.
Okay, so maybe we could refer to that. Again, in red, were just suggestions from the last meeting. So we can talk point by point about every single one of these bullet points to see if you want to add these to the recommendation or not. And so let's start with the first one, improve provider and patient education. So you as a work group had talked about, appropriate uses of the technology and making sure the quality of care was there. Is the bullet point that is written here sufficient to your sentiment? Would you like that added to the recommendation for this year?
This is Jennifer with KHA. I think introducing the word e-health is going to create a whole new layer of confusion. So I would suggest we use something different than that word.
This is Shauna Wright with the Center for Telemedicine. Can we just use telehealth if that's what we're talking about? And I would even go so far as I agree with Eileen in terms of the next bullet. Could we say something about, we're talking about provider and patient education. Can we fold the cybersecurity or HIPAA into that first bullet? Because I think it's more about educating, not creating standards because those are already there, but including them as an educational focus.
This is Connie. I absolutely agree with that because we don't want to do anything. I mean, we need to be on the same path as the feds, and we need one regulation in terms of cybersecurity. So it's the education of it that's real important.
Hi, this is Sunny Mickle from Blue Cross of Kansas. I was wondering from the revisor's perspective, Eileen, you say that this was covered in HIPAA. So how do we assure that this is actually happening? I think that's the reason this work group talked about this, because there was concern in making sure that all providers are aware and are being held to the same standard. So does there need to be a statement made in a statute, or is this being covered today in the current Telemedicine Act?
I'm sorry, Sunny, can I rephrase your question? Am I understanding that you're asking if patient education is included in the Kansas Telemedicine Act? Is that your question?
Yes, I'm asking because you were pointing out HIPAA to us, and I was trying to flip through a little of a lot and realizing that HIPAA does cover so much. So is that part of the standard of care? The references to HIPAA in the current Telemedicine Act, do they actually provide this banner of expectations on the patient education, the cybersecurity, or are we asking too much and should go ahead and try to word this out in statute?
Well, I think HIPAA pertains to the covered entities of which, the healthcare provider is one. And those are professional responsibilities on the covered entities. They already exist in law. It's HIPAA, it's federal law, so state law would not supersede anything there. As far as education goes, I think everybody goes to the doctor's office and has to sign a HIPAA statement, a HIPAA waiver document that states the patient's rights, et cetera, regarding privacy. I don't know that those waivers that they sign in the doctor's offices are standardized. I don't think they are. I think they just list the pertinent provisions in HIPAA. I would suggest that there be something that a telemedicine provider offer along those lines.
Thank you. So that is something then that could be expressed so it's clear to providers and anyone reading the Telemedicine Act that is an expectation.
I don't think that that's necessary. I think HIPAA's already stated there, and it says that those provisions apply via telemedicine. I don't think it's up to the state to dictate how that happens. I mean, they know that they have to do this. I think that's provider education versus something that we codify in law.
So Hinesha, KHI, go ahead.
Okay, Representative Landwehr here. I would say that we leave it like it is, and then we can do some checking into that, a little further, so we can find out, what's standardized, what's not standardized, how we use the HIPAA language where, rather than making a final decision on that today. So that would be my recommendation at this point on the the top two, and then we can get to number 3.
Any other thoughts on that? Otherwise, the last piece is on the interstate compacts, highlighting kind of practitioner confusion around that and serving patients across different states temporarily.
Okay,
Can I-
here, Representative Landwehr here. I'm concerned with medical licensure compact
Mm-hmm.
because we have created, and Eileen might know better than I, we've created different levels of compacts. And I know that yesterday I read an article that there's now also an APRN compact. So medical licensure, what's that mean?
Hi,
May I cut in for just a minute? I had a question on the last thing, and maybe you didn't see my hand. This is Representative Neighbor, and I will say that with my practice in medicine, the HIPAA sheet is usually stated as the feds have written it. And so when you look at that most of the time is, I want to say generic, because they take that. They may offer some of their office things at the end of it, but those are pretty much straightforward as far as the HIPAA law is concerned.
Thank you, Representative Neighbor.
Hi, Hina. It's Eileen from the Revisor's Office. And to answer Representative Landwehr's question, I would rephrase that because there is an interstate medical licensure compact that pertains only to physicians. So if we're addressing the need for compacts to license other professions, I think we need to state that versus using a specific name that's already codified.
Yes.
Hi, this is Dennis Shelby, Wilson Medical. If we needed a statement like that there, it would need to be more general, like medical professional licensure compact, something to that effect that would cover the different levels like LCSWs, MFPPs, all those kinds of things.
Yeah, this is Shauna Wright from the Center for Telemedicine. As we focus on behavioral health, I think that, since that's the purpose of the mental health modernization, it's behavioral health professionals as well as medical professionals, because we need all levels. So we're looking just like he said, the social workers, marriage and family therapists, advanced practice nurses, psychiatrists.
Hi, it's Eileen from the Revisor's Office again. I would say establish a need for those compacts because all those compacts are governed by a governing body that negotiates out with each state what the standards should be, and how reciprocity happens and the language and all. If you read any of the compacts, they're quite lengthy, and there's a board and there's appeals processes and so on and so forth. And if the state wants to leave, I don't think Kansas can establish its own. I think that we need to just say that there's a need for this type of compact currently.
Hi, Eileen, this is Connie Freeze. And another path to get there without doing a compact is what we just enacted in 6528,135. Again, I bring your attention back to paragraph G, which would allow the mental health licensure board to come up with a waiver program for these types of
Connie, I'm trying to avoid throwing Dave under the bus and saying that that's something, I'm trying to avoid putting requirements on his agency, but that would be one way of doing it. I would also point out, though, that this would address the need for more behavioral health professionals to practice in Kansas. Anything regarding reimbursement of those professionals via their practice with a waiver is not contemplated within the Telemedicine Act. This is just, as I stated before, this statute only addresses the scope of practice and the ability of an out-of-state professional to obtain a waiver to practice within Kansas. It does not address reimbursement of those professionals at all.
And I agree. I wasn't wanting to address it. I thought that.
No, Connie, I just wanted to make it clear.
Okay. To other,
There's a specific delineation. That's why this one statute lives in Chapter 65 and reimbursement lives in Chapter 40 of the statutes.
Any other comments on this? It sounds like we have kind of two different paths that the group can think about. Do we want to let everyone sit on this and then we can revisit it at our next meeting once you have a chance to think about it?
This is Shauna Wright from the Center for Telemedicine. I would like to invite Dave to talk with us more in depth about what it would mean for the BSRB in terms of, legislatively looking at something like SIPAC versus a waiver. The thing that I keep in mind is that Kansas is much different than many other states where we have an omnibus behavioral science regulatory board, where many other states that join compacts have, they'll have a psychology board, they'll have a social work board. This is a lot of work in one agency, and they do a really good job, but it's a lot to manage from one agency. So I would like to hear more from him if he's able to share his perspective at our next meeting.
Dave, did you want to say something now? I saw you on mute.
Is it okay if I go ahead and respond to that? Okay, this is Dave Fye with the Behavioral Sciences Regulatory Board, and I appreciate that. One thing I wanted to mention today is I really appreciate being invited to the meeting, and as you mentioned, we do oversee several different mental health professions. There's 7 unique professions under the BSRB, and there are some significant differences between the different professions, as they all involve different criteria in different areas of mental health. And there have been some compacts that have been started, and there are some other ones that are in development currently. One thing that's important to note, we do have a board with 12 members that have professionals and public members, and so I don't want to speak on behalf of the board, but the board does do a great job of looking into any of the details on proposed compacts and has advisory committees to review those things too. So I'd be happy to go ahead and talk to the members of the board and bring back any comments from them on those. But there are significant differences, and there's significant differences in terms of what Kansas looks at for licensure versus what maybe some other states have for standards. And so there's a lot of things to consider, but I'd be happy to come back at another meeting if you'd like me to and talk more about some of the things that the board has discussed in terms of evaluating these items.
Thank you, Dave. I'll be in touch about that. Hinesha, KHI. I'm going to move us along just for the interest of time to the next recommendation. And this one is for 10.3 on telehealth for crisis services. So take a second to read it. And again, based on the conversation from last time, there's some drafted language in red, and you can react to that. All right, so would you like to add a statement to this recommendation for 2021? The red text is just there from what was discussed, however you would like to wordsmith it as well.
This is Shauna Wright from the Center for Telemedicine. I see the who developed, put the question mark there. And I wonder, I don't have a specific response there, but I wonder, Oklahoma's been doing this work. Can we reach out to states that have stood up their co-responder models and do a little research in terms of what training they received, there obviously have to be best practices that are developed. And we don't necessarily need to develop those ourselves, but can we talk with other states that are further along in the process and kind of evaluate their resources and see if they fit for Kansas?
Any other comments? And I can remove that. That was just one question.
This is Sunny Mickle, Blue Cross and Blue Shield of Kansas. I really support what Shauna stated. I think that's a great idea. So we can actually learn from best practices at our places that have already gone through this, and let's learn as much as we can from them. Thank you for that.
Any other thoughts? Go ahead.
Well, this is Jennifer from KJ. I just have a bigger picture, maybe clarifying question, and I apologize because I am still new to this group. When we say we are making a recommendation, who are we making the recommendation to? What is bigger picture? How is all this coming together?
Sure. So you are a work group that was convened by the special committee. I think Representative Landwehr is off now, but the special committee on mental health modernization and reform is an interim committee by the legislature. And so this report is part of the report that is developed by that group to the legislature. So that is your audience.
All right, thank you.
Any other questions? Oh, go ahead.
Yes, Rennie McKinney at Advent Health. I would also be willing to reach out to just our local mental health center who has an expansive co-responder program, and they actually take the lead on the National Co-Responder Convention here in Kansas. And so I'm sure they have some best practice as well to add to what Sunny was saying about Oklahoma.
Terrific. So we will wait to hear about this Oklahoma model and perhaps a local model as well, and then incorporate best practices into this recommendation. Is that what I'm hearing?
Hey, Hina, this is Kyle Kessler.
Mm-hmm.
And again, Kyle Kessler with the Association of Community Mental Health Centers. So, and I have some research that I can forward along from my counterpart in Oklahoma that I had received about a month ago. And they've actually done a report out of Oklahoma. Their program's about a year and a half, 2 years old, and has seen a lot. And a lot of this was done in conjunction with their Certified Community Behavioral Health Clinic model, or CCBHCs, and then mobile crisis response. Being something that's connected to that, and using iPads and tablets. They're really getting, as much as it pains me to say that Oklahoma is getting a great deal of notoriety out of doing something positive. This is something that they're doing pretty well. So I don't know that we're to a place where there's been fidelity and actual evidence-based practices established, but certainly there's some things to be learned there, and I can forward on that. I mean, it ranges from news articles to an actual report their state agency put out, I believe.
Thank you. All right. Any other comments? Otherwise, I will move us on to the next recommendation. So take about 5 to 10 seconds to read this one about originating and distant sites. So there are several pieces that you talked about for revisions. The only one provided is kind of to this first revision of improving provider and patient education around originating and distant sites and how these regulations impact their services. Again, suggestions on changing the language there. How do you feel about your first possible revision?
Hi, this is Sunny Mickle from Blue Cross of Kansas. Regarding the provider and patient education, I think I'm not as sure now about that based on what we've learned from Eileen today in reviewing the Kansas Telemedicine Act. And the fact that when she explained how the originating site and distant sites are very broad as they stand today, you know, what are we trying to clarify? I think I just want to make sure that we understand what we're trying to clarify, because it seems like the current law already addresses this.
Does everyone agree with that?
I would
Rennie
agree with
McKinney at Advent Health, and I would say I got a lot of clarification from Eileen's presentation, and I think Had we had that first, we wouldn't have all these questions on our list.
This is Connie Freeze. I totally agree with Sunny. I don't think we need to clarify. It's broad enough. And it's actually ahead of its time. I think we're going to see some coding changes, and our current definition is consistent with the coding changes we're going to see for telehealth. So I don't see any changes are needed.
And I would agree with what Sunny also stated. Sometimes you can get the same thing over and over again. And I think after hearing Eileen discuss the act itself, it pretty well defines without having to talk about the patient education in every little place. So.
Great. How about your second revision on quality of care? As it's covered in the Telemedicine Act, is that sufficient? Ensuring standard of care? And then the third piece is on regulation and administrative burden. Any comments based on that revision? Anything you want to add to the recommendation? And we do have David Fye here if you have any questions around administrative burden. Susan Guile, who is the acting director right now at the Board of Healing Arts, is available for questions via email, just not available on this meeting at this time.
Can I ask a question? This is Jason from the University of Kansas Health System.
Sure.
I'm curious about the under the recommendation, allow staff to provide services from home or other medical or non-clinical sites if the patient privacy and safety standards can be met. Did we define who actually says the privacy and safety standards have been met? Is it an opinion? Is it, I'm a patient, I'm in a crowded room, and I'm receiving my care? Is it the physician who stops that conversation and says, I don't believe you're in a private room? Or is it the patient who says, we're good, let's just keep going? Did we have any recommendations around what we know? Because my concern is, and I've read many other state laws, and I've seen this language in other state laws, and my concern is that the patient can come back and say, you know what, I feel like you said something that got out in the public, you should have told me to stop. So I'm just kind of curious as to how we're kind of defining who actually says privacy and safety standards have been met to continue this conversation via tele.
Dennis Shelby, did you raise your hand?
Yes. I think I read yesterday when I was reading some of these attachments that the term they used was non-public. And I don't know if non-public answers your question, meaning that you're not around other people. Am I mistaken on that?
Yeah, I think we could say things like that. I just kind of my question around is who's on the hook for actually saying, I still don't believe you're in a non-public area, or I'm going to actually tell you something incredibly sensitive, and it appears that I can hear, or I'm just kind of curious if the patient's like, just tell me, I don't care, but the doctor is like, So I just don't know if in our recommendations we need to not only have this, but we also have to kind of define both parties agree that it is okay, or both parties agree that it's okay to move on. Because the moment that camera flips on for that patient, the physician kind of assumes the patient readied themselves prior to the appointment starting. And the physician assumes that the patient picked a location that was private, because they're essentially, by turning their camera on, they're saying, I agree right now that we can do this. So I just worry that when I look at some of these laws and language that we can get ourselves into a rock and a hard place when someone says, hey, you told me I have a very serious condition, but I wasn't in a private spot. And we just need to kind of define do both parties mutually agree at this moment that we are okay to safe, just along those lines.
Thank you. Dorothy, do you have research along this that you'd like to discuss?
And can I add something real quick? This is Shauna with the Center for Telemedicine, which all of your points, Jason, are great. But I think that the way I read this bullet point is allow staff to provide services from their homes or non-clinical sites. So what I believe you're speaking to is a very pertinent issue on who determines the privacy of an appointment. But it sounded to me like you were talking about the location of the patient, the originating site. Whereas I believe this statement reflects more on the distant site, saying that we want to allow providers to be able to work from their own homes or a non-clinical site if within that environment they can make sure that they're meeting privacy and safety standards. So I think those are two different points. I don't want to neglect the point that you just made.
No, that's really good. Thank you. Because now when I read it again with what you just said, I can see it framed that way, right? With the onus is on the staff.
Right. But if I could add comment to what you said, in terms of, and I may be biased, when it comes to who's on the hook, inevitably, I think the person who can lose their license is on the hook for maintaining privacy. And sometimes we have to say, I'm sorry, but the produce aisle in Dillon's is not the best place to receive care. And if we haven't prepared you through our organization or through our telehealth patient education to not turn that camera on in the produce aisle at Dillon's, then we need to rethink that. But the provider who needs to be compliant with HIPAA and needs to follow the standards and protocols that their organizations have handed down, it really is, I believe, on the provider's shoulder to follow the law and to protect their licenses.
Shauna, it's Eileen from the Revisor's Office, and you're absolutely right. The HIPAA controls for rules regarding privacy and confidentiality. So it's the covered entity that needs to be cognizant that they can be fined for disclosure of an individual's personal health information. So I don't think it's a licensure issue, just by the way, but the onus is definitely on the provider to ensure that their practice has prepared the patient that the patient needs to be in, a spot where they can focus on what the provider is saying without confusion or other competing things for that patient's attention. And I laugh because I'm thinking about my dog that just, will appear on conference calls and such, very unexpectedly. But it's up to the provider to make sure that the patient is prepared, because it's ultimately the provider who can be disciplined.
Thank you. So again, keeping us on track, any other edits that you want to make to this recommendation? Do you want me to add this clarification of distance site, or can we keep it as is?
Well, this is Jennifer from KHA, and looking at this now in the context of what we now better understand about the definitions in the current Telemedicine Act, I think you could combine bullets 1 and 2 and just say adopt the broad definitions of originating site and distant site consistent with the Kansas Telemedicine Act. I believe that's what our discussions were really about last time, was just providing as much flexibility on both sides as possible.
Okay.
This is Shauna Wright. I wanted to ask Eileen, does the Telemedicine Act define distant site, or does it only define the originating site?
Shauna, it's definitely defined, KSA 40-2, 211. I'm also going to say that, again, if these recommendations would become legislation, they would become part of the Telemedicine Act, in which case those definitions would apply. So my recommendation would be to use the definitions in the Kansas Telemedicine Act just to save any confusion to providers who may not look in 3 different places if we have 3 different definitions.
So I'm hearing that we actually put the originating and distant site definitions of the Kansas Telemedicine Act as bullets 1 and 2. Is everyone in agreement with that?
This is Shauna Wright. I wanted to ask Sunny a question. Again, I apologize. I wasn't able to hear Eileen's review, and I'll go back and listen to that. But I believe that this came up with something that Sunny mentioned in one of our meetings in terms of defining the location of the provider and how that is an extension. If it's a home office, it may be an extension of an organization. I believe that that's where this bullet point, the second bullet point came from. So Sunny, since I missed the original or the initial part of this meeting, does this cover everything that was of concern previously?
Hello, this is Sunny Mickle from Blue Cross of Kansas, and yes, it does. And I was so happy that Eileen explained everything. We had worked on this before, but there were a lot of different thoughts on how it actually was operating in Kansas. And I think this clarifies that the intent of the law is to have the broad definition on both the originating site and the distance site. So for the distance site, wherever the provider is, under the current telemedicine law, as long as that provider has a Kansas license, they're able then to provide telemedicine or telehealth from that distance site. So this satisfies me, and I don't think there's a problem at all. Thank you.
Thank you. Then in the interest of time, I'm going to move us on to the next recommendation, which is on child welfare system and telehealth. There was some discussion around the unique needs of the parents. And so instead of consider, I had heard the word explore. Is that something you want to change and modify in this recommendation, or do you want to leave it as is? And the other focus was on consistency of care. And this one with consistency of care was really thinking through where the child is placed, because placements are frequent. And so if they are receiving care from a local CMHC and then going to another one, can they continue the care with their initial CMHC? So any edits to this recommendation or discussion?
This is Shauna Wright with the Center for Telemedicine. Would we say consistency of care, or is it continuity of care? I know it's semantics, but I'm used to the terminology continuity. And I don't know if Kyle Kessler had anything to say about, or any additional information he can provide about the county of residence and responsibility when it comes to community mental health center service provision, especially if community-based services are involved. If a child maintains treatment with a therapist in one county, but then is physically located in a county that has a different mental health center and a different fiscal responsibility, I guess.
I would look at the same. This is Cindy. I'm sorry, Representative Neighbor, and I would support Shauna's comment, because in the leading paragraph, it talks about continuity as children. And so this just keeps the language on the same page. It keeps continuity in the entire description. Thank you.
I'm hearing no changes, or go ahead, Kyle.
I'm sorry. This is Kyle Kessler with the Association of Community Mental Health Centers. A couple thoughts on this. One would be when we talk about the SED waiver for severe and emotional disturbed kiddos, this has been something that in the child welfare system, this transitions me back to a previous life or two. I think there's been a history where it's really challenging for kids to start SED waiver services with one CMHC when they may be placed half the state away with a foster home disruption or something like that. I think telehealth really holds the future to helping the population, because there are things that they just don't get to participate in, whether it's wraparound facilitation services or parent support, which would be so helpful. So I think that really figuring out what the best way to integrate telehealth into SED waiver and foster care services is would be a great priority. And so it really just adds into this. You all have done the heavy lifting on it already. I think as it relates to supporting parents, excuse me, there is a code, I want to say 90846, which we talked about at length in the Mental Health Modernization and Reform Committee last year, which is therapy without the patient present. And that's another one. If you have a child currently placed in Cottonwood Springs at a foster home, but the parents are in Topeka or Salina, and you're trying toward reintegration, and you're able to have a therapy appointment with those biological parents, or it could even be foster parents, or potential adoptive parents, and they may not be covered by Medicaid or another insurance provider, then this is an absolute premium opportunity to implement telehealth, I think.
Would the work group want to add any steps to include based on Kyle's comments? Or would you like to keep it as is, the language?
This is Shauna with the Center for Telemedicine. I think based on Kyle's comments, I like the word explore more than consider, because there are many things that some of us in this group may not understand about some of the systems that provide care for children in the welfare system. And so I think we need to keep an open mind and continue to look towards how to best serve children in the foster care system.
Does everyone want to change that to explore instead of consider? All right, I'm seeing head nods, and then I'm going to remove the steps to include so we can continue exploring. All right, moving on to the last recommendation, 10.2 for reimbursement codes. Here's the original language, take about 5 seconds, and the two revisions that you had considered were a clearer definition of telehealth and expansion of codes, and then starting our discussion on payment parity.
It's Eileen from the revisor's office, and I'm probably overstepping right now, but I'm kind of under the impression that HIPAA already contemplates coding, and that there are CMS codes and requirements in there. Sunny or somebody from the provider side can probably help me out with this, but I was under the impression that there are standards already, so clarification and expansion might not be something that's feasible with regard to a change in coding, because there are already guidelines in place.
Yeah, this is Connie from Blue Cross Blue Shield of Kansas City. And if we're talking about the Telehealth Act right now, I agree that it requires that we cover whatever we would cover in person, we would cover via telehealth. And so whatever those codes are those codes, and then you add a modifier to it to show that it's via telehealth. So is this pertaining to Medicaid or some other program, this recommendation?
This is Andy Brown with ks, and this is specific to Medicaid and to our block grant services.
Okay, I'll get out.
During the public health emergency that was declared by HHS for COVID-19, we expanded the number of codes that were available in those programs for use of telehealth and telephonic services.
Thank you, Andy. During the last meeting, one thing that had come up was the second sentence under the first one of addressing differences between codes for Medicaid and private insurance. Is that something that the group wants to do under this recommendation or another recommendation?
So if I may continue that discussion, because the Commercial Telehealth Act is so broad and says we have to cover everything that we would cover in person, whether it's behavioral or medical. And it appears that Medicaid has a much smaller list of what it would cover for telehealth. I I think you should probably just focus on the Medicaid.
Is that the wish of everyone?
Well, this is Sunny Mickle from Blue Cross of Kansas, and I agree, and I appreciate the clarification from Andy about what this was referring to. I think that we were trying to figure that out last time, and that's where we started broadening that revision. So I think it should be more restricted back to Medicaid.
This is Jennifer with KHA, and I agree with what you all have said, taking into consideration the comments that Representative Landwehr made about how it is very difficult to draw the line between between behavioral health and regular other kinds of telemedicine. I would propose that we revise this recommendation to say maintain Medicaid reimbursement codes added, but take out the word telebehavioral health. And so we're making a general statement that whatever Medicaid reimbursed via telemedicine during the pandemic, we would like to see that continue.
Does everyone else agree with the edits I just made of adding the word Medicaid and removing the behavioral? So it would say telehealth services.
It's Sunny with Blue Cross of Kansas, and I agree. Thank you, Jennifer.
I agree as well. This is Dennis Shelby.
Terrific. So we are about 4 minutes from the end of our meeting today. And so I'd like to take this time to ask, there was a worksheet sent out to all of you to really think through and compile some issues or recommendations or things you want to talk about. I received about 4 recommendations. I'm just going to pop them on the screen so you see them. But what do you need from a supplemental expert standpoint for that conversation? Your next meeting is on November 15th. Is there anyone that you would like to hear from at that meeting as you discuss the issue? Whether you develop a recommendation or not is up to the working group, but as you discuss the issue, do you want anyone else in the room there with you?
This is Jennifer from KHA. I know we are one of the ones that submitted a worksheet, and I referenced a group that is out there that has done a lot of research into all states, what their current statutes say, and has done a lot of work specifically around the issue of payment parity. And since we mentioned earlier in this discussion, really wanting to understand what other states do, they could be a very valuable resource to us in looking at some of that. They are funded through a grant that the Federal Office of Rural Health provides to help support the expansion of telemedicine activities.
Thank you, Jennifer. And yes, I will go back through that worksheet and reach out to that group.
This is Renee McKinney at Advent Health. Just as a side note, is there any data available in terms of what we were doing in terms of telehealth prior to March 11th of 2020 and what we've done since within the behavioral health realm?
I can reach out to the agencies to see if there's such data there. KDHE might have some, and so I don't think I see anyone from KDHE on right now, but I can reach out to them.
Yeah, this
Just
is
thinking it might be pertinent for future conversations.
Yeah, this is Andy Brown with KDAD. So Rennie, are you talking about like Medicaid utilization data, or what kind of information are you looking to identify?
I'm thinking all of behavioral health. We all feel like we're using telehealth a lot more. Do we have data to support that? To say whether it be commercial payers or Medicaid, at what level have we seen an increase? I know I read articles, but for Kansas specific, I don't know. Does Blue Cross have data on how much of an increase? Does Medicaid? I don't know. I just was wondering. I think that would help us as we're moving forward in our conversations.
Thank you. I will reach out to those entities.
Can I
if
ask a quick question? I just want to clarify. When you're talking about data, this Connie Freeze from Blue Cross of Kansas City, are you talking about utilization? Are you talking about what we've paid for? What specific data are you looking for?
Oh, thank you, Connie. I was referring to utilization.
All right, we are at 2 o'clock. So the only other two announcements I'm going to say is one, you can email me any further questions or supplemental experts that you would like to invite. Email them only to me, please. And then second, the special committee is meeting on Thursday, October 28th. Your co-chairs will be presenting sometime between 10:20 and 11:20. That's the time for it. If you are a roundtable member, you'll receive a WebEx link from Robin. If you aren't, you can watch on the legislative YouTube site or listen on Harmony. And those are both accessible, and I can send those out to you as well. So thank you so much for joining us. If you have any further questions and such, feel free to email me. Take care.
Thank you
Bye.
so much for your time. Bye-bye.